Good morning. I want to thank the organizers for inviting me again to this beautiful city. And I want to thank my colleagues for presenting. It seems this is a very pragmatic approach, which I like. So we heard a lot of interesting information about treatments, screening tools. My presentation is going to talk about housing these in one comprehensive, user-friendly setting and the issues to make that happen. So my name is Jason FARRELL. I am from Amsterdam, as you could tell from my Dutch accent. I am working with the Correlation Network. We are a network of over 100 organizations throughout Europe, working primarily with drug users. I am involved with the European Hepatitis C and Drug Use Initiative, doing capacity building, policy work, and developing an online resource center, and doing many trainings as well. So, hope I get this right. Okay. So, with the growing need to treat hepatitis C, needle exchange programs have been identified in numerous stakeholder meetings as the ideal settings to offer the integrated care, testing, treatment referrals, and prevention interventions. However, despite the effectiveness of harm reduction programs and NSPs, and these numerous stakeholder recommendations, including pharmaceutical companies, they continue to remain underfunded and understaffed. The presentation will highlight many of the challenges that these programs encounter to effectively implement recommended Hep C prevention and treatment support services, even on-site treatment. So we know, as many of us heard in the past day or so, the grueling statistics. There are about 1.2 million people who inject drugs living with Hep C in Europe, and the prevalence is about 44%. Increases have been primarily in Belgium, Cyprus, Greece, and Turkey. In spite of the EU guidelines recommending treatment access, people who inject drugs still face barriers and are frequently denied access. And access to low-threshold comprehensive hepatitis services is very low as well. So we are aware of many recommendations for interventions. WHO has guidelines on HIV interventions and Hep C interventions, and still today, despite their recommendations, which include, and this is from 1990, okay? And this is for HIV. And today we have problems, harm reduction programs have problems implementing these. Basic needle syringe, OST, testing, ARV, STI, and as I highlighted, hepatitis diagnostic services, treatment, and vaccination. Today we have point-of-care services that can be delivered upon enrollment and triage at any of these programs within 15, 20 minutes. So research shows that providing the testing in locations other than laboratories has been highly effective in reaching injection drug users. Research has also showed that targeted testing interventions were associated with increased treatment uptake. Also, that notifying people of their hepatitis status has reduced risky injection behaviors. We also know that connecting people to evidence-based interventions keeps them from engaging in risk behaviors. It actually minimizes and can eliminate risk behaviors. So we don't have any cohorts of post-treatment injection drug users enrolled in behavioral interventions, which we know can work. We've seen that with HIV. And Also, these studies have shown in the few studies that have been conducted to date that this is very effective. So when I talk about an integrated care model, something I pioneered many years ago in New York City. So a needle exchange program or harm reduction program normally has an intake or a triage session. And during this intake and triage, you provide basic information about needle exchange, safe injection. If they're not drug injectors, other drug-related information, overdose prevention. You can immediately provide hepatitis A and B vaccinations. You can do rapid HIV testing, rapid Hep C testing, rapid STI testing, and provide treatment on demand right then and there if their medical services co-located, or make a referral to medical. Once you do that, you can enroll people in what we call behavioral interventions on site, the counseling services. They can be individual and group interventions. And most of these services should be provided by peers. Drug users, or in some cases, when absolutely required by some people, it'll be former drug users. We recommend hiring drug users and incorporating them in the delivery of day-to-day services. So what are these challenges to do this? Well, funding, infrastructure, staff skills, knowledge of hepatitis, and EU and national policies. So for example, funding. The harm reduction HRI did a study on the global state of harm reduction, and we've seen decreases in funding. These decreases in funding directly affect the provision of services and distribution of needed supplies. For Hep C prevention, a large number of various supplies need to be provided consistently. This requires a lot of money. So if any harm reduction program is going to be effective consistently, they need adequate supplies of prevention materials. Not just needles and syringes, but information on how to safely prepare drugs for injection, information about other drug use, club drugs, cocaine use, how unprotected sex directly attributable to drug use can precipitate infections. Poor fundings also affect the organization's ability to recruit appropriate skilled staff, which also affects infrastructure. So many NSP's harm reduction programs are operating with volunteers and with very little administrative support. Most funding actually allows a very small percentage to be dedicated towards administrative support, which is a problem. Today we see NSP programs just managing to deal with day-to-day issues, let alone have time to engage in strategic planning. And integrating Hep C services will require having dedicated staff to do the Hep C services, data collection systems, and ongoing training, support, and supervision. Okay? Historically, the programs have hired former drug users or drug users. With added Hep C prevention services, we will need trained and well-supervised staff. Whether they're drug users or ex-drug users, not the point. They need to be trained and well-supervised. And with little in addition to administrative supervision, clinical supervision is needed and rarely provided. Every day, people who work in these settings are exposed to not such nice things. People getting sick, people dying. Where is the clinical supervision to prevent burnout? Training volunteers and supervising less skilled staff, as we may know, is very time-consuming, time many organizations do not have. Behavioral interventions, rapid testing, pre- and post-test counseling, partner notification, all require knowledge and experience with counseling interventions and techniques. Motivational interviewing, open-ended questions, all these things take time and skills and supervision. Knowledge. After recently conducting hepatitis treatment advocacy training in Europe, we've learned at the Correlation Network that there is a huge gap in knowledge of Hep C prevention, safe injection techniques, and treatment among the staff, peer workers, and volunteers. Inconsistencies in knowledge. Huge gaps. Safe injecting techniques to prevent Hep C are not well known, and it varies on what's okay, what's not okay. Information about risks of sharing drugs and household risks have been neglected in most educational sessions. When I tell people, if you've been tested for Hep C, and you go to your boyfriend or girlfriend's house and use their toothbrush, you might give your boyfriend and girlfriend hepatitis. And they all look at me shocked. You know, something as simple as that, you could spread hepatitis. So these are some of the things that really need to be put out there, especially when governments are making people wait until they become ill to start treatment. So in that time period, how many people are going to be infecting other people? Which goes to the policies. Limitations of testing are not only due to the funding and staff shortages, but policies are the largest barriers to date. Despite the WHO's strong recommendation urging testing in non-clinical settings, many countries have policies preventing both HIV and Hep C community-based testing. Current policies creating barriers to increase the testing actually include only medical personnel can test, that testing must be in a medical clinic, testing must be supervised by a medical person, or only saliva tests can be used. These are all problems. Countries with low barriers to community testing include France, Greece, Hungary, Italy, Portugal, and Spain, and the UK. But still, in these countries, peer workers are not going out in the field, or it's not being done in the needle or harm reduction programs. So when we talk about preventing Hep C infections, what can we do now? That doesn't really involve a lot of money, right? So identifying individuals by checking risk group boxes on forms not fitting all multi-risk behaviors doesn't help our work. For example, MSM individuals, you check the box, MSMs do drugs. IDUs are not all heterosexual. So if I check MSM, immediately, oh, they don't use drugs. If I check IDU, oh, they're not gay. No, not true. Therefore, more choices. MSM, DU, MSM, IDU, IDU, MSM. As we learned in the transgender community, you have male to female, female to male, right? Not transgender people are not gay, right? So, services should be accommodating to the needs of the individual, not perpetuating stigma when individuals find it safer only admitting to a socially acceptable risk behavior. If I'm gay, I'm not going to say I use drugs because it's easier for me to talk about my sex. If I'm a drug user, I'm not going to really talk much about my sexual practices, what I might do to get money, or what I might do because I am gay. There's a double stigma in many of these communities that needs to be addressed. Checking boxes doesn't help. Drug users are all sexual orientations, genders, sizes, and colors. Therefore, harm reduction services must be tailored to the specific needs of individual risk behaviors, not a group. Yeah? Recent data shows that Hep C is increasing in the MSM community attributable to drug use and unprotected sex. Therefore, needle exchange programs need to get with the program. They can tailor their services and reach the gay community. It's not that difficult. So, suggested solutions. As experts determined in stakeholder meetings, harm reduction programs are best suited to screen and prevent and provide the ongoing support to minimize high-risk behaviors. Harm reduction programs have consistently proven year after year, otherwise they'd be shut down if we don't prevent blood-borne infections and change risk behaviors. And not only that, we connect people to care. Policy and laws need to change, allowing peer-delivered community-based Hep C rapid testing, and with appropriate resources and training, harm reduction programs can become state-of-the-art, multi-service integrated care and treatment centers. With proper strategic planning and tailoring of services, harm reduction programs can be welcoming to all. And that is it. Thank you so much. Any questions? No? Okay. Thank you. I'll be happy to talk to you later.